Okay, so some are still joining in. Okay, so for this afternoon, our topic would be hypertension in pregnancy. So in your lectures for the past week, we have you have learned that hypertension is one of the conditions wherein um, has a great effect on pregnancy and how we manage our patients in the emergency room setting. Okay, so for this afternoon, we will have a case regarding this disorder. Okay, so at the outpatient, hey, at the pregnant patient seeks consult to you for your first prenatal checkup. Her last menses was February 6, 2021. Upon doing initial vital signs, you found out that her blood pressure was 130/90. So what are the additional information that you will need for this patient? What do you need to establish? And how will you manage this patient at this point in her pregnancy? Anyone may start.
Ma'am, we should first ask the maternal age and then we calculate the age of gestation.
Okay. What is the age of gestation of this patient?
It's around 24 week.
Okay, around 24 weeks. Okay. So age of the patient matters. What else matters? Age of
Also the
gestation. I agree. What else?
also the family history of hypertension.
Okay. Any family history of hypertension na itiben.
And ma'am, we can
Any
also ask
other
patient she has
before
hypertension
pregnancy
before.
with hypertension?
One by one. Any hypertension, any history of hypertension prior to this pregnancy? That's correct. Jill. Ruth.
Doc, we can ask if she is
Pregnancy is also hypertension.
no. We can ask she is primary gravida or like parity or
Okay.
paridity because
We
primary
ask
gravida has a higher risk.
okay, parity is important. What's more, what proposes a higher risk as far as
Smoking.
parity is concerned?
Primary gravida has a higher risk. Doc.
Okay, primies have higher parity, or if your patient has changed partner for first exposure to a partner's sperm cell, that also increases risk. Okay, anyone else? That
Doc, we asked,
anything? Om
Doc, we,
Prakash.
yes, Doc. Doc, we asked the personal social history that she is smoker or drink alcohol. Anything.
Okay. Smoking history, alcohol history. Shalu Patel.
If she is having any vision problems or any kind of pain,
Okay.
abdominal pain,
Any blurring of vision? What kind of abdominal pain are you specifically looking for?
epigastric pain,
Okay. Epigastric pain. This pain in hypertensive patients is caused by what? Yash. Yash Dilip.
Yes, Doc.
This pain in the epigastric area is caused by
Right upper
what?
quadrant.
What is the pathophysiology?
Doc, it is due to the stress. Doc,
Yes.
it is due to the stress in the right upper quadrant.
Stretching of
Stretching.
what?
stretching of liver capsule, doc.
What is the name of that liver capsule?
Subscapular, doc.
Anyone who would want to help? Clerk
Gil-
Milin? Yes.
Gilson capsule.
Okay, it's the stretching of your Gleason's capsule. Okay, what
Yeah.
other information do you have to elicit in this patient?
Doc,
Doc,
we asked diabetes or she is obese or not.
Okay, BMI, obesity, stature of the patient, diabetes. Ready?
Drug or cocaine use.
Okay, drug use. What else?
hello, Doc. As her last menstrual period was on February 6, so we need to also ask blood pressure before February, before she
Yes.
get pregnant.
Establish if there is any hypertension episodes prior. Okay. What else?
Doc,
History.
maternal age.
Maternal age has also been asked. What
And
else?
if she has hypertension before pregnancy, so she taking any medication for the blood
Okay.
pressure.
If there is any intake of medications um, during this pregnancy, especially if patient says that she is hypertensive. Okay. What else?
And
Thyroid
also,
levels product. If she is
Thyroid.
having hypothyroidism or hyperthyroidism, uh,
Do we ask that baseline in all our patients?
we will check for us to get the reports of the TSH, T3, T4 levels so that we can suspect if she is having hyperthyroidism.
Why is it important to rule out thyroid in a hypertensive patient?
Because hyperthyroidism can lead to the thyrotoxicosis, which will lead to the chronic hypertension.
Okay. But hypertension came first. Maybe if you establish that this patient is hypertensive, then you see if there are hyperthyroid symptoms, then you could request for your thyroid panel. Thyroid, we have to have judicious use of our labs because laboratories would be expensive. Are you happy with the information that you have gotten so far?
Doc, BMI,
Hobbies.
high body mass index.
Yes, BMI has been mentioned. What else?
and ma'am, we can
Doc,
ask also the past medical history of any liver, any renal disease.
Okay, it may be essential hypertension. Okay,
Doc, we can also ask for any history of heart diseases, so that can also lead to increased hypertension.
what disease? What disease will you ask?
Disease. We can ask if the patient has any heart disease,
Oh,
such as
heart disease prior.
heart
Okay,
disease. Yeah.
sorry. All right. So knowing these things, you know that patient is hypertension upon physical examination. How will you manage this patient at this point in her pregnancy?
Let me first give the aspirin.
Okay, what are the medications that we will prescribe? Aspirin. What is aspirin for?
Doc, aspirin will be thrombox alpha 2 inhibitor. So
And why
that
do we give it to our hypertensive patients?
it make a blood less viscous. Uh, so there is the decrease the chance of the preeclampsia.
Okay, it decreases your chance of preeclampsia. What else can you give this patient?
And we also tell the patient to do exercise or low fat food. or low
Okay,
sodium diet.
low salt, low fat diet. Okay. What else?
We can give our patients some vitamins and folic acid.
Okay, we don't forget that the patient is also pregnant. So we give our um, vitamins and ferrous sulfate, folic acid for our patient. What else?
Monitor to the blood pressure daily at the home.
Okay, advise the patient to monitor blood pressure at home. Okay, what else?
Doc, before starting,
Ma'am, we will check for blood pressure between the interval of 4 hours to see if the patient has preeclampsia or not.
How will you establish at this first meeting if patient has preeclampsia or not?
hello, Doc.
Yes.
Doc, as she consult first time, I think, so we don't have to start treatment for blood pressure initially. We need to monitor again after 4 hours. We cannot start the treatment based on only one finding. And also she has mild hypertension, as the criteria is not matched for the mild hypertension, which is 140 systolic and 90 diastolic. So we need to wait, and we have to take again blood pressure after 4 hours.
Okay. If after 4 hours you found out that the blood pressure is the same, what will you do?
Doc, we can start the labetalol.
Labetalol is one option. What are your other options? If you're in the Philippines, what is your option?
Methyl dopa.
Okay, your methyl dopa is another option.
Doc, what
Okay, how
about
will you give your methyl dopa?
Orally.
What is the dosage? Would you know the dosage?
250 milligram.
50 mg, 2 3 mg divided into 2 dose, doc.
Again. What's your dosage of methyl dopa?
250 to 500,
250
500
milligrams
3 days.
divided in 2 to 3 doses. Okay. What's your maximum dose for your methyl dopa?
3 gram per.
Okay, you can give up to 3 grams. So if you have a 250 milligram tablet, that is how many tablets per day?
12, Doc.
That's 12 tablets per day. So you could give up to 4 tablets 3 times a day. Okay. What are the laboratory tests that you will request for this patient?
Doc, we can request for
Doc, liver,
proteinuria.
Okay.
liver enzyme
How
test.
will you establish your proteinuria?
Uh,
Dipstick test po, Doc.
For
Dipstick.
24-hour test.
Okay, you could do a dipstick at your clinic or a 24-hour urine test at the laboratory. Okay, what else? What other labs will you request for?
Doc, lactic dehydrogenase, liver enzyme, and to check for the platelet count is very important at this point of time. So we have to order CBC also.
Doc, creatine levels.
Okay, CBC with platelet, liver enzymes,
BUN po, Doc.
LDH,
Doc, lipid profile.
AST/ALT, your liver profile. What else?
Clotting
BUN.
study.
BUN, CREA.
Yes.
What else? Are your baseline preeclampsia lab, um, preeclampsia labs for the pregnant? What else?
And clotting
Fatty
study.
level.
What?
Serum creatine.
Serum bilirubin, Doc, and also 24 hours urine protein excretion.
Already given. Oh, you're forgetting. Okay.
LDH.
Oh, you're focusing on the hypertension. Okay, remember your patient is pregnant. Ask your other pregnant labs as well. Okay, so don't forget. Okay, so this would be the results of your laboratory. I'm sorry. These are the results of your laboratory. Okay, so what is your working impression at this point?
It's
Ready.
gestational hypertension.
Gestational hypertension. Why gestational hypertension?
Is still not proteinuria, ma'am.
There's no proteinuria. What else? What are your
And
other?
she is getting hypertension after 24 weeks. So it is gestational. If there is chronic hypertension, so she might be having before 20 weeks of pregnancy.
Okay. So if it's less than 20 weeks, it may be chronic hypertension. But after 24 weeks, after 20 weeks, gestational hypertension, unless your proteinuria or your laboratory results prove otherwise, or if your patient becomes symptomatic. Until when could you have your gestational hypertension?
12 week after delivery, doc.
Okay, until 12 weeks after delivery. If your hypertension persists beyond the 12 weeks, what then will you label that patient?
Preeclampsia, superimposed hypertension.
No, for example, nothing happened, no proteinuria, etc. Just the hypertension
Pregnancy induced.
persisting.
Chronic hypertension, doc.
If it persists, okay, your chronic hypertension already because it persists beyond 12 weeks. Okay. You also requested for a transvaginal ultrasound. Not yet. Oh, this pa lang. So blood pressure after 2 months. So that is 24, 32 weeks. On follow-up, blood pressure was found to be at 140 over 100. At this point, what are the questions that you will ask this patient at this consult?
And we can ask she has noticed any blurring of
Blurring vision
vision
and
and
Okay.
headache.
You ask for the blurring of vision, headache, epigastric pain. What else?
If swellings is present in the legs or not.
If edema is present. Before, edema was one of the favorite criteria for preeclampsia, but not anymore so. Okay, but still, it is one one of the signs that patient may have peripheral vascular resistance. Okay, what
Doc,
else?
pulmonary edema, doc.
Pulmonary edema. How will you assess if there's pulmonary edema? Okay, what else?
Doc, can we ask the patient, is patient taking medicine regularly or not?
You could ask for if
Patient is taking medicine regularly or not?
okay, you ask if the intake of medicine is regular or not. How else?
Urine output, ma'am.
It's outpatient. So how would you manage this patient? as far as fetal maternal surveillance is concerned?
Ma'am, we request first the uterine artery Doppler.
Okay, we ask for ultrasound, particularly Doppler. What will you look for in your Doppler studies?
Doc, in uterine, difference between the systolic and diastolic wave. We can we can see the diastolic notch during a diastole in Doppler.
Hmm? We look for what do you particularly look at?
Systolic diastolic ratio, whether it is increased or not, doc, and the diastolic notch.
Okay. Notching. Okay, what else?
Ma'am, and diastolic flow.
And diastolic flow. Of what? What arteries in particular?
Uterine artery, doc.
Your uterine arteries. Okay. Okay. So these are the new lab results. Okay, at 32 weeks. So what does this affect your impression?
No, ma'am, because it's still the normal, not met the criteria.
Check your laboratories again. What the does it change your impression?
LDH is above 600.
Okay.
But
What
24
does
is
that tell you?
ma'am, it's met the criteria of preeclampsia. But 24 hour urine is 250. It's less than 300. So
What else? What else could
platelets is still not less than 1000. Is 140.
okay? What are the criteria that you use to establish? What syndrome are we looking out for whenever we request for these labs?
Health
Health
syndrome.
syndrome.
Helper syndrome.
Okay, what does HELP syndrome mean?
Hemolysis, elevated liver enzyme and platelet count.
Okay, how elevated should be your liver enzymes be?
2 times to
Twice.
normal value.
Okay, so it's still within limits. Low platelet. What is considered low platelet?
Less
Below
than
1 lakh.
1000.
Less than
1 lakh, doc.
less than
100K.
less than 100.
100K.
What
100K.
criteria are you using?
Tennessee.
Kinesis criteria.
Okay, if you are using the other criteria,
Missionary criteria.
what is the other criteria?
Missionary.
It's not missionary, but close.
Mississippi triple classification, doc.
Okay, what's your Mississippi classification? This further divides your platelet levels into 3 based on platelet counts. Okay, and what does this tell you? If it's less than 150, it could already be classified um as a mild class 3, mild um deranged platelets. Okay, so your LDH is also deranged, so that gives you 2 out of 3. So more or less, we have to look after this patient more closely than your other patients. Okay, but other um, other parameters are still within normal limits. Okay, your Doppler is repeated also, and says that both uterine arteries with end diastolic notching. So how will you manage this patient? Do you admit or send this patient home?
Ma'am, we can give hypertension and have close fetal surveillance.
Close fetal surveillance. Do you terminate or we allow
No, ma'am.
patient to continue with her pregnancy?
Then we allow.
We allow, but with close fetal surveillance. And what are the parameters that do we have to fulfill to ensure that the baby is fine, or we are doing adequate fetal surveillance?
Steroid for
Again?
Steroids. And we will deliver after 48 hours maybe.
Okay. Steroids deliver after 48 hours. So if you give steroids means you will commit to delivering the baby. Am I correct?
No, ma'am, we can, at this point, we cannot terminate the baby because
we have a lot of things to consider. Um, as long as your baby is fine, although we cannot send this patient home. So close monitoring, just in case something happens. Okay. Repeat Doppler. So shows absent end diastolic flow. So elevated indices in the uterine arteries. How then will you manage this patient?
now,
So
ma'am, we can
we have
terminate
to
pregnancy.
terminate.
Okay, now we have to terminate because of the absent end diastolic flow. What is more ominous, the absent or the reversed end diastolic flow?
Reverse and diastolic flow, doc.
The reversed because that is, what does that mean if it's reversed? I think this is my last. What does it mean if it's reversed?
The blood flow is going in the anti-gravity directions. So,
Okay, so it's like right to left shunt already. Okay,
yes.
so this will benefit from termination if patient is um, not in labor. You do your cesarean section. For example, this patient had an eventful, just hypertensive, and went into labor spontaneously. What is the recommended vaginal delivery method? How will you deliver the baby if it's vaginal route?
Doc, can we deliver like a normal delivery? But
Yes, if it's
before that, we
vaginal,
have to control our blood pressure.
as long as your hypertension is controlled, how will you deliver vaginally?
Give oxytocin and deliver.
Uh, what kind of vaginal delivery do we do?
Doc, you mean
Assist,
to say
I think I heard it. It Ben, or was it you?
assisted vaginal delivery.
Assisted vaginal delivery, either by what? What are your assisted vaginal delivery that you learned, that you know of?
Instrumental.
What instrument will you use?
Forceps and vacuum.
It could be either forceps delivery or vacuum delivery under epidural anesthesia at least. Okay. Why do we have to do assisted vaginal delivery for hypertensive patients?
Because we cannot give oxytocin. That's why, doc, I think.
Can we not give oxytocin to our hypertensive patients?
We can give doc.
Hmm?
Doc, it's contraindicated, but I don't know. I'm not sure.
Doc, I think we can still give oxytocin, but the assist is needed because too much contraction will increase the blood pressure of the mom. So that's why they have to assist her with the vacuum.
What do we aim to achieve by doing assisted delivery?
For concern for the fetus heart rate during the labor.
Is it more for the fetal heart rate? What
I
do we
think
aim to shorten?
to shorten the time of the delivery.
Why?
Because the pregnant woman is already having so much high blood pressure, so she can't afford to take delivery that is going to take so much time, because that would exhaust her so much. So they have to do the procedure as quick as possible.
Can we
Doc,
shorten?
there are concern about fetus rate during the labor, and the long time pushed inside, and fetus head stop moving the down to the birth canal, and very tight from the long labor. So that's why we assist the vaginal delivery.
To prevent the eclampsia of the patient.
What's the second active stage? So that's when we ask the patient to bear down. So for hypertensive patients, we aim to shorten that second stage so that we avoid hypertension to occur and make the second stage shorter. Okay? Of course, with your epidural, so that the mother won't feel any pain, the hypertension or the blood pressure won't go up. Okay? Okay, I think that's the end of my slides. Could you open your camera and Amit, could someone take the screenshot and then send to me? Open. Okay. Okay, thank you. If you don't have any questions with regards to hypertension, you may leave this call. Thank you.